Before we get into the steps of neonatal resuscitation, let's just review some of the basic facts. Most neonatal resuscitations can be anticipated. That's why neonatal resuscitation starts off with asking the three main questions before or during every delivery. Every birth should be attended by at least one person whose primary responsibility is the baby. Depending on where you work, this could be a nurse practitioner, a neonatologist, or it could be a respiratory therapist. It just depends on the culture of your facility. Someone at the delivery should have the skills required to perform resuscitation. The skills include performing the resuscitation algorithm, providing positive pressure ventilations, and compressions. A second person should be in the hospital and able to respond if needed. Additional skills that are needed are intubation and ordering medications. Neonatal resuscitation is intended for neonates. About 10% of all deliveries will require resuscitation. 80% of the low birth weight babies will require resuscitation. Any neonates that experience an asphyxiating event during birth and preterm neonates are the primary ones that will need resuscitation. Just a quick review of the fetus circulation. In utero, the fetus's organ of respiration is the placenta. So as long as the placenta is delivering oxygen and removing CO2 from the fetus, then delivery should go as planned. With each contraction, the placenta is compressed, the fetus is compressed, which causes normal asphyxia. So oxygen levels drop, CO2 rises, and the body becomes slightly acidic. The normal response from the fetus then is to have fetal heart rate changes in response to those contractions. This was part of the birthing process. Anytime that the blood flow from the mother gets completely shut off to the baby is when the baby is going to experience abnormal fetal asphyxia. There's a decreased blood flow to the brain, carbon dioxide rises, and the blood flow becomes more acidic. So just a ground where we're starting from. Okay, we have reviewed that normal asphyxia is part of the birthing process, but what happens when there is an abnormal asphyxiating episode? And that's what we're going to look at here. So in this situation, an abnormal or severe asphyxiating episode occurs. It could be that the umbilical cord is compressed. It could be that you just notice late or variable heart rates in the fetal heart rate monitoring. But either way, you recognize that an asphyxiation is occurring to the fetus. In the fetus, the chemoreceptors and baroreceptors are going to be stimulated. The stimulation of those are going to cause rapid fetal respirations. Remember, fetal respirations, the fetus is just moving fluid in and out of their lungs in utero. So amniotic fluid is being pushed in and out of their lungs. If you look at the diagram right below the picture of the baby here, going left to right, you see the top line, you see rapid fetal respirations or fetal breathing movements, okay? Along with that, if you look at the heart rate, you see the heart rate slowly starts to rise, and then along with that, you see the blood pressure also starts to rise. So the increase in respirations, the increase in heart rate, and then the blood pressure takes a little bit longer to rise, but then the slow rise in the blood pressure are all a result of the stimulation of the chemoreceptors and baroreceptors to a negative asphyxiating episode. After that, if the hypoxia doesn't reverse, okay, the fetus is going to go into what's called primary apnea. So this is where their fetal respirations or their fetal breathing movements completely stop. Okay, that is a very, very bad sign. Once that happens, there isn't enough oxygen in their blood for their tissues, and the CO2 in their body is too high and they're too acidic to resume normal fetal respirations after that. So at this point, if they haven't been delivered, we're heading into some trouble. Okay, so after the primary apnea occurs, they're going to attempt to breathe again, but it's not going to be effective. So if you look at the top line right after that primary apnea, you see how those lines are jagged and not as tall and regular as the other ones. Well, those are the measurement of the fetal breathing. And you notice it's irregular, it's not as strong as the ones prior to the apnea. So as this continues, the heart rate is unable to increase to its normal level. You see the heart rate where the irregular respirations are occurring. You see the heart rate there is at 100 and dropping. At this point, you see the blood pressure is peaking, okay, and then it's going to dramatically drop. So the heart rate continues to drop, the pH continues to drop, the PO2 continues to drop, and the CO2 is going to continue to rise. Then the baby is going to go into what's called secondary apnea. Now, all of this can happen before the baby's delivered, or it can happen after the baby's delivered. We don't really know. So anytime a baby is born and they either have weak and gasping breaths or they're completely apneic, we always assume they are in secondary apnea and we act very quickly to provide positive pressure breathing. Okay? Anytime a baby's born apneic, always assume secondary apnea and react quickly. This is where the neonatal resuscitation program comes into play. As we mentioned before, most of the time we can predict when resuscitation is going to be needed. For example, if it's a preterm delivery, we know there's going to be poor compliance due to lack of surfactant, and most likely they're going to have weak, ineffective breaths, so they're going to need some resuscitative efforts. On the other hand, if through fetal heart rate monitoring we see abnormal decelerations that tell us something is wrong or that the fetus is being asphyxiated abnormally and significantly, then we can also predict that patient is going to need resuscitation. So now we move on to the algorithm. Okay, so here's a picture of our NRP algorithm. And remember, we always start with the first 3 questions. As soon as you're called to that delivery room or you know that delivery is coming up, you should be asking at least the first question: is this a term gestation? We know if it's preterm, we're probably going to need some resuscitative efforts. The next question, you would ask yourself this as soon as the baby's born: is it breathing or crying? And next, does it have good tone? If you have a yes to these 2 questions, then you can probably pass the baby along to the mother and just provide routine care. However, if you have no to any of these, so if the baby is limp, if it's flaccid, if it's weak in crying and gasping for breath, or completely apneic, any of those, you're going to begin warming and drying immediately, which also provides stimulation for the infant. At this point, you're reaching at about the 30-second mark. You should be assessing the heart rate. You can do this by palpating the umbilical cord or listening to the heart, either way. If the heart rate's below 100, you're going to begin delivering positive pressure ventilations immediately. If the baby's gasping or apneic, you do not need to count the heart rate because you've already tried stimulating it with the drying, and this means they're still not effectively ventilating, so you don't even need the heart rate in this situation. Just go ahead and start providing positive pressure ventilation. Hopefully by this time somebody else has got an SpO2 monitor on the baby. Hopefully they even have the EKG tabs in place. And so after 30 seconds of providing positive pressure, you're going to reassess the heart rate. If the heart rate is still below 100, then you're going to take corrective steps with your ventilation. Reassess your positive pressure ventilations. Make sure you're getting a good chest rise, chest movement. Make sure there's no leak. Make sure you're not obstructing the baby's airway. If your ventilation is effective and the heart rate is still below 100, you may want to start considering putting the patient either on CPAP or intubating and ventilating. If the heart rate at any time drops below 60, this is when we're going to begin delivering compressions. Compressions start below 60, ventilation start below 100. Okay, let's go back to the top here. So let's just say after we've warmed and dried the baby, we provide that stimulation, we assess the 100 and it is above, we assess the heart rate and it is above 100. but we notice there's still some labored breathing. At this point, we want to clear the airway. If we hear there's obstruction in the airway, like still some fluid in the back of their throat, we can do that with a suction bulb. If they're not turning pink as they should, or any signs of a little bit of labored breathing, that would be your nasal flaring or retractions, then we might want to consider just putting them on CPAP and giving some positive pressure for them to overcome that airway resistance or the compliance of their lungs. Okay, that's the basic overview of the NRP algorithm. You'll notice further down when we talked about starting compressions, if the heart rate's below 60, at this point you kind of keep going back to the same process. Do compressions, provide PPV, make sure it's coordinating, and reassess the heart rate. If it's continually below 60 and it's not rising, again, you're going to need to get the baby intubated at some point. You may need to deliver some epinephrine. You might want to consider hypovolemia or a pneumothorax and take corrective actions for that. Typically, we don't get that far. Most babies turn around after we provide some positive pressure ventilation and their heart rate stabilizes above 100. But this is the algorithm. You really want to have this down pat because this is what you would be using with every delivery.